CHO, Professor Jain sir, to speak on ESC guideline on update on atrial fibrillation. Dr. Jain sir, please.
I would like to thank Dr. Alok for so wonderful scientific feast and must congratulate the whole team. Thank you, chairpersons, for kind words and the topic given and already instructions given that I have to finish in time and less than 10 minutes. So I would like to highlight the latest ESC guideline for the management of atrial fibrillation. So the updates and the new recommendations we will discuss. So these are the new recommendations. Diagnostic evaluation for new AF. So they told that transthoracic echo is recommended. It's a class 1 indication now with an AF diagnosis where this will guide the treatment decisions. So transthoracic echo in all AF patients. Education directed to patients, family members, caregivers, healthcare professionals is recommended to optimize the shared decision making, facilitating open discussion, both benefit and risk associated with each treatment options, including the latest treatments available like the LA appendage occlusion and ablations, different types of ablations available. So access to patient-centered management, so all are class 1 recommendations. Access to patient-centered management according to the AF care principles is recommended in all patients with AF, regardless of gender, ethnicity, socioeconomic status, and to ensure the equality of healthcare provision and improve the outcomes. With the devices which are available, AF is not it's very common entity in the population. With the help of devices, they are able to get diagnosed AF, the subclinical AF, and now they give the class 1 guidelines to access for the patient-centered management. So patient-centered AF management with a multidisciplinary approach should be considered in all patients with AF to optimize management and improve the outcomes. So the role comes with the cardiologist, with the physician, with the cardiologist, with the electrophysiologist and the surgeons. So role is there for all. Comorbidity and risk factor management. So diuretics are recommended in patients with AF and heart failure for decongest to alleviate the symptoms. So class 1 recommendation. Appropriate medical therapy for heart failure in heart failure patients for reducing the hospitalization and AF recurrence. SGLT2 inhibitors are recommended. Now these are the class 1 recommendations in heart failure with AF patients. So regardless of LVEF, it may be preserved or it may be reduced. If AF is on board, then SGLT2 is the class 1. So class 1A. Effective glycemic control is also recommended to reduce the AF burden. So it's a class 1 recommendation. Then bariatric surgery, that may be considered, it's a class 2B still. And management of OSA is also a class 2B. And they are telling that OSA only basis of questionnaires diagnosis is not recommended. We have to do sleep study. Then we can initiate the oral anticoagulation. So in patients with clinical AF at thromboembolic risk, so ischemic stroke and thromboembolism prevention, it's a class 1 indication for oral anticoagulation in appropriate patients. So we calculate this score, CHADS2-VASC score, and if it is 2 or more, then recommended as an indicator for elevated risk, class 1. If it is 1, score is 1, then it's a class 2A indication for anticoagulation, oral anticoagulation. It is recommended in all patients with HCM or cardiac amyloidosis, irrespective of the score. So without scoring, we can go ahead in SCM patients and amyloidosis patients. Class 1 recommendation is there for the oral anticoagulation. Then individualized assessment also required for at periodic intervals to ensure the anticoagulation is started in appropriate patients. So once you start, we should not forget reclassify them according to the needs. Direct oral anticoagulants, drugs, may be considered in asymptomatic device-detected subclinical AF and elevated thromboembolic risk. So this is device-detected. The patient is already having some pacemaker device implanted and it is detecting the AF. It's class 2B indication for oral anticoagulation. A reduced dose of DOAC is not recommended. So unless the patient meet DOAC specific criteria to modify the dose. So dose of DOAC should be ensured on a recommended dose. Otherwise, it will not come to the optimum prevention of the thromboembolism. Maintaining VKA treatment rather than switching to DOACs may be considered in patient more than 75 years on a clinically stable therapeutic VKA level with polypharmacy to prevent the excessive bleeding risk. So they are preferring VKA. It's a class 2B, although adding antiplatelet to oral anticoagulation is not recommended in AF patients with the goal of preventing ischemic stroke. So no rule of antiplatelets if there are not compelling indications like ACS or something, PCI, then the antiplatelet should not be added. It will increase the bleeding risk without giving benefits of prevention of thromboembolism. Residual ischemic stroke risk despite anticoagulation. So a thorough diagnostic workup should be considered in patient taking oral anticoagulation and presenting with the stroke to prevent the recurrent events. So once a stroke is on board, then we should assess the residual ischemic risk and we should find out the non-cardioembolic causes, vascular risk factors, dosage and adherence. So class 2A indication. And then adding antiplatelet to anticoagulation is not recommended. And switching from one drug to another or drug to VKA without clear indication is not recommended. Then another important thing is surgical LA appendage occlusion. So surgical closure of LA appendage is class 2A indication as an adjunct to oral anticoagulation in patient undergoing endoscopic or hybrid. Hybrid is surgical and catheter both ablation to prevent the ischemic stroke and thromboembolism. So if the patient is going for surgical approach, then they should also close this LA appendage. Standalone endoscopic only surgical closure of LA appendage may be considered in patients with AF and contraindication for long-term oral anticoagulation. Then we can think of surgical closure of LA appendage once we are going for the endoscopic procedure. It's a class 2B still. Then a specific antidote should be considered in AF patient on DOAC who develop bleed. So these are available. Then management of heart rate in patient with AF. So rate control in patient with AF as an initial therapy is class 1 in acute setting and as an adjunct to rhythm control and as a sole treatment also to control the heart rate and reduce the symptoms. So rate control is class 1 alone or with the adjunct to rhythm control. Then beta blockers, diltiazem, verapamil and digoxin. These 4 drugs are there on board for first choice in a patient with AF with LVF more than 40 to control the heart rate and reduce the symptoms. So these 4 drugs we should not forget. AV node ablation combined with the cardiac CRT so should be considered in severely symptomatic permanent AF patients. Permanent AF patients which are severely symptomatic and they are being hospitalized at least once for heart failure, they should undergo AV node ablation with CRT. So the heart failure patients may be given the benefit of CRT with the AV node ablation. Then general principles and anticoagulation. So DOACs are recommended in preference to VKA in eligible patients. Class 1 recommendation with AF undergoing cardioversion for thromboembolic risk reduction. So when we are cardioverting them, it's a class 1 indication for DOACs. Cardioversion of AF should be considered in symptomatic patients with persistent AF as a part of rhythm control approach. So once you are going for this, it's a class 2A indication. And a wait and see approach is also there, class 2A indication for waiting for a spontaneous conversion of sinus rhythm within 48 hours of AF onset. If we are knowing the onset, we can wait for 48 hours to revert it. If it is without hemodynamic consequences, then we can wait. It can be used as an alternative to immediate cardioversion. Implementation of rhythm control should be considered within 12 months of diagnosis in selected patient of AF, at least thromboembolic event, to reduce the risk of death and hospitalization. So rhythm control should be thought within 12 months so that we can get the success of rhythm control. So earlier is better. Early cardioversion is not recommended without appropriate anticoagulation or TE if AF duration is longer than 24 hours. So if it is more than 24-hour old AF, definite AF, we should do a TE or we should do the appropriate anticoagulation. Electrical cardioversion as a diagnostic tool should be considered in patient with persistent AF, where there is an uncertainty about the value of restoration of sinus rhythm. So we can do electrical cardioversion as a test whether it is going to sustain the rhythm control or not. So it's a two-way recommendation. Then antiarrhythmic drug is not recommended in patient with advanced conduction disturbances unless antibradycardia pacing is provided. So it's class 3. Then catheter ablation. So sinus node disease, tachybrady syndrome. In this, AF catheter ablation should be considered in patient with AF-related brady or sinus pauses on AF termination to improve the symptom and avoid the pacemaker implantation. We can go for the AF catheter ablation. It's a class 2A indication. Then recurrence after catheter ablation, then repeat catheter ablation should be considered in a recurrence case and provide the patient symptom were improved after initial catheter ablation. If it is recurrence and previously he was improved symptoms, then class 2A indication for repeat catheter ablation. Anticoagulation in patient undergoing catheter ablation. So we should uninterruptedly give the oral anticoagulation. The patient is undergoing for catheter ablation to prevent the periprocedural ischemic stroke. So oral anticoagulation is a class 1 continuation of oral anticoagulation. Endoscopic in hybrid AF ablation. So this is another approach, surgical approach along with the catheter ablation. So in this also continuation of oral anticoagulation is required for preventing the periprocedural stroke. So class 1 indication. During cardiac surgery, AF ablation, so intraprocedural imaging of LA thrombus detection is recommended. So we should do some TE or something when the patient is going surgical ablation to prevent the periprocedural ischemic stroke. And concomitant surgical ablations should be considered in patient undergoing non-mitral valve surgery. So in mitral valve we do surgical ablation, but in non-mitral valve also it's a class 2A indication. Evaluating quality and of care and identifying opportunity for improvement of treatment of AF should be considered. And acute and chronic coronary syndrome patients. So these patients are recommendations of AF with CCS. So antiplatelet beyond 12 months, we should stop the antiplatelet in stable patients with chronic coronary or vascular disease due to lack of efficacy and to avoid the major bleeding. So up to 12 months we can continue, but after that we should stop. Then trigger-induced AF, long-term oral anticoagulation should be considered in suitable patients in trigger-induced AF, which is transient AF. And post-operative atrial fibrillation, so perioperative amiodarone is recommended when drug therapy is desired to prevent the post-op AF. On patient with embolic stroke of unknown origin, so oral anticoagulation is not recommended, class 3. Atrial flutter, we should give the oral anticoagulation. Screening strategies for AF, so we should do a review and ECG by physician when we are diagnosing the AF. And primary prevention, so we should maintain the optimal BP, we should treat the heart failure therapy, maintain the normal weight, we should give the active lifestyle, avoid the binge drinking, and metformin and SGLT2 is class 2A in patients needing diabetes therapy for, and weight reduction is also. So this will complete the new recommendations in these guidelines. So I will stop here.
Any question from the audience?
I have one question for Dhamend. As usual, enjoyed your talk. I just want to ask you one thing about this choice of the oral anticoagulants. Because nowhere it was very specific about whether you should use the VKA or NOACs.
Very clear, boss. Very clear. No confusion. If it is valvular case where you have to give VKA only, and non-valvular case, non-valvular AF, it's DOACs.
So isolated AFib, there was one slide where it was mentioned with class 1 and I think B indication that more than 75 years of age.
That one exception is there.
So VKA
can be continued if they are already
maintained.
Pharmacy.
Yeah.
Already maintained.
Yeah.
So we can continue.
All right.
Why to disturb?
Now I request Dr. B.K. Singh sir to give memento to Dr. Dhamendra sir.